Hello, and welcome to Dr. Wagner's Health Behavior Theory video series. This is the health belief model. The health belief model is one of the most popular models or theories used in health education and promotion. This is partially due to its simplicity in design, as well as the ease with which we can apply it to almost any health-related issue. For starters, notice that the health belief model has 6 major constructs, all of which are going to help us focus on a person's understandings and attitudes related to whatever health issue we're working with. It's important to notice that 4 of the 6 constructs of the health belief model are focused on perceptions. Perceptions are an individual's understandings of things, irrespective of how those things actually exist in reality. For example, if a person thinks they are overweight, that is more important than if they really are overweight or underweight, because that's where we need to start with them. As the health education specialist or health coach, it's important to have a grasp on what this individual or population's reality actually is, as one element of health belief model is going to be to help align their perceptions with reality. So let's start with perceived susceptibility. Perceived susceptibility is a person's belief about how likely the health issue is to affect them. So are the consequences of the action or inaction likely to affect them or unlikely to affect them? When I talk to my students about texting and driving, for example, often they'll report to me that they're actually really good at texting while driving. Now, irrespective of their actual ability to do this, there's a pretty significant amount of data that says the human brain is really not as capable of multitasking as we've given it credit for. See bandwidth research. So whether or not we think we're good at driving while texting, the evidence is that we are not. In fact, a person who is texting while driving has about a 24 times greater chance of crashing than a person not texting while driving. And we can compare this to drinking and driving, where we find from the research that a person under the influence of alcohol has a 4 times higher risk of crashing than a sober driver. So keeping with this example of the person texting while driving, their perception of their susceptibility might be, first, that they're skilled at texting while driving, and so an accident is not likely something that they will be involved in, or at least not something that their distraction would be the cause of. Additionally, they might also not be concerned about being involved with law enforcement. On the other side of this example, folks might believe that their susceptibility is actually really high. So one might believe that their risk of contracting coronavirus, for example, is pretty good. Moving forward to perceived severity. Perceived severity is a person's belief about the consequences of the action or inaction. How bad would it be? So our driver who is texting while driving might not think the ticket that they get for distracted driving is that big of a deal. The flip side of this would be the person who's concerned about the dangers of texting and driving and therefore avoids it or limits it as much as possible. Our coronavirus example is timely in that perceived severity will detail the intensity of our coming into contact with coronavirus. So here again, a person might have low perceived severity and believe they are likely to be asymptomatic or have very mild symptoms, or a person might have high perceived severity and be concerned about long-term hospitalization, mortality, or lifelong health consequences yet to be determined by medical research. Coronavirus is a great example for this construct, as the research doesn't yet point us to obvious implications of infection with coronavirus, meaning essentially that we have no idea if an individual gets sick, how sick they will be on the continuum of asymptomatic to mortality. Perceived benefits and barriers go together, with perceived benefits being the individual or population's beliefs about the good things related to the action or inaction. So the person who's texting while driving likely believes they are multitasking and therefore being highly productive. A barrier then would be that perhaps they feel like just driving isn't enough activity for that time. Perhaps they have a busy schedule or are stressed out, and therefore they believe that by answering that text or having that communication while they are driving is facilitating the completion of actions on their large to-do list. Many of us have phone anxiety. So every time the notification dings, our brain is alerted to an important, air quotes around important, event or occurrence that requires our immediate attention. And our inability to quiet this voice or anxiety often leads us to participate in a behavior we might otherwise consider to be health negative. If we relate these to coronavirus, perhaps we want to insert the idea of wearing a mask and social distancing, for which the perceived benefit would be protecting ourselves and those around us from transmission of the virus. The barriers would be that the masks aren't really that comfortable, that they impede our social interactions and are just generally annoying, let's be honest. So the trick here for the health educator or health coach is to find the sweet spot of balance between the benefits and the barriers. We need to identify these from the individual and then help ensure the benefits outweigh the barriers while also being honest about both. So the perceived barriers then are the individual or population's beliefs about the things that might impede the action or inaction, essentially the things that interfere or get in the way of us doing the thing, right? So if we don't take barriers seriously, we're not likely to reach that population. So if we argue that masks aren't that big of a deal to wear, or that condoms aren't that much of an interference in a sexual encounter, for example, we're likely to lose our audience, as it is pretty well understood that not wearing a mask is more comfortable than wearing a mask, and sexual behaviors without a condom are going to have increased sensation over those with a condom. In any of these examples, it's our job, as I said, to help alleviate those barriers by providing tips and techniques to reduce their impact. Okay, so then cues to action are going to be anything that gets the person ready for doing the behavior or avoiding the behavior. And these might be intentional or sporadic. So if I'm driving in a neighborhood that has distracted driving laws, a sign letting me know that texting while driving is a misdemeanor carrying a $500 fine, for example, might be something that gets me to put my phone down. I don't have that kind of money to pay a ticket. It might also encourage me to do so. A sign on a business entrance that says masks are required may encourage, or in fact here require me to put my mask on if I wasn't already disposed to do so. So those would be intentional. And unfortunately, cues to action can also be sporadic, meaning we don't really have control over them, but we can use their presence as learning opportunities. So if my friend gets a serious ticket for driving and texting, or perhaps worse, causes an accident or is involved in an accident involving texting and driving, especially if I previously thought that person was a good driver, right? I might be more likely then to take the risks of driving and texting more seriously. Likewise, when someone I know comes into contact with coronavirus, irrespective of how they experience that, I am likely to feel at increased risk. This is probably especially true if the person's consequences with coronavirus are significant. So if my friend ends up having a serious interaction with coronavirus and has serious health complications, that also is likely to spur me into more rigorous preventative actions. The last construct of health belief model is self-efficacy. And self-efficacy is an individual's belief in their ability to act or not act. So how confident am I in my ability to text and drive? Side note, not so much. How confident am I that I can leave my cell phone aside while driving? Oprah, in fact, used to talk about, while you're learning this, perhaps put your cell phone in your purse, in your trunk, to really encourage yourself to leave it alone, for example. Boosting self-efficacy for health positive behaviors is really important. Encouraging a person to wear a mask and maintain social distance. Giving them tips to make sure they will continue in those behaviors even when those around them are not would all be examples of boosting self-efficacy. It's not enough to just assume a person will believe they can do something because we've told them how, or we've shown them what those actions are, or because we think the action is simple. Keep in mind, self-efficacy is about attitudes as well as actual skills. So it is possible for a person to communicate with a partner about disease prevention methods, for example, but to say that getting a partner to comply with condom use every time is easy would be inaccurate. This is not because talking is difficult or condom use is difficult, but rather that talking about such a sensitive topic, especially in a heightened state, can be difficult. And the same goes for wearing masks with relation to coronavirus. Very few people have stable arguments that wearing the mask is very difficult, but how confident we feel in our ability to do something like wear the mask, even in a situation where perhaps other people are not doing so, would be the measurement of self-efficacy for this example. So measuring a person's self-efficacy means how confident do they feel about having that conversation, and refraining from behaviors that don't include those protections would be what we're talking about here. So the health belief model takes these 6 constructs, all that are interrelated to each other, and helps us create a picture of the health issue at hand and to focus specifically on what elements of a person or a population's understanding we want to focus on. So when would we use the health belief model? The health belief model is best when we're looking to understand people's beliefs such that then we can more accurately focus our interventions on which of their beliefs are a little bit out of line. We also use this model to target cognitive dissonance and clean up conflicts in people's beliefs patterns that conflict with each other. So if I value my health but won't wear a mask in public, that's a conflict the health belief model can help us clean up. We also can use the health belief model to strengthen our health positive beliefs and also adjust our health negative beliefs, with which would both generally encourage our beliefs to fit the realities as they exist in real life. So that's really all for the health belief model as one of our health behavior theory videos. I really appreciate and thank you for your attention, and I hope you found this video to be helpful. Be on the lookout for other health behavior theory videos in addition to the worksheets available to you through our course. Thank you so much.